Well, welcome everyone. We're very excited to have this webinar today, speaking about the impact of the healthcare cuts in the future of rural surgery. This is being hosted today by the Southeastern Surgical Congress Rural Surgeons Committee. I'm the chair of that committee. I wanted to give a huge thank you to all the other members of the committee, and in particular, Dr. Shively, who was instrumental in making this happen. Very excited to really talk about this important topic today and hear from some big names in the field. And so we really are looking to get a perspective from multiple angles. So we have a representative from rural hospitals, as well as academic referral centers and safety net hospitals, because we all know that these cuts are going to have really big impacts. And while we're looking at it through the lens of rural surgery, of course, this is an issue even bigger than that. So I thank you all for your time, and we're going to get started. I'm going to do a brief introduction of each of the speakers that we're lucky enough to have with us today. So speaking first, we actually have Dr. Hugh Schaff. He is an assistant dean for quality and patient safety at the University of Louisville School of Medicine. He is the associate chief medical officer at the University of Louisville Health at the University of Louisville Hospital. And I also have to give a huge thanks to him for stepping in at the last minute, because in what is entirely ironic, the individual who was supposed to speak, Dr. Watkins, oh no, I'm sorry, not Dr. Watkins, Dr. Smith, was called to go speak to representatives in our government because of impending cuts to Medicaid in Kentucky, and had to go there urgently. So, Dr. Schaff, thank you for your time. Next, we have Dr. James Watkins speaking on behalf of rural hospitals. He is the Chief Medical Officer at Taylor Regional Hospital. Dr. Watkins has over 30 years of surgical experience. He's highly rated by patients for his thoroughness, communication, and follow-up care. Very excited to hear how this is really impacting you. And then we also have Dr. Rob Todd. He is the Executive Vice President and the Chief Medical Officer at Grady Health System in Atlanta. In September, Dr. Todd joined the Impactful Leaders podcast to discuss sustaining excellence at a safety net system. So maybe you can keep us speaking how we should on a webinar. You have some experience with all this, and look forward to kind of your point of view from safety net hospitals. And then when we get to our panel discussion, we'd also like to welcome Dr. Wendy Green. Dr. Green's a professor of surgery with research interests in health equity and outcomes in the emergency, general surgery, and critical care patient population. She is an American College of Surgeons governor representing the surgical section of the National Medical Association, and has led the Inclusive Excellence Pillar. She's the founding member of the African American Women's Collaborative and Interprofessional Affinity Group at Emory School of Medicine, and the Right Path Health Equity Scholars Program. So look forward to hearing from you. And Dr. Green has let us know that she has some ideas for how we can fix this. So look forward to hearing those. So we will get started with Dr. Schaff. So as everybody's probably heard, we're going to kind of give everyone about 12 to 15 minutes to speak. And then at the end, we'll have a Q&A. If you have questions, feel free to put those up in the chat, and we will get to those as we go along. So Dr. Schaff, I'm going to go ahead and hand it off to you.
Yeah, thanks, Dr. Hewitt. And thanks everybody for being here to listen to this. This is something that I think is really going to impact all of us in some form or fashion, and something that we need to be aware of and ready for as we come down, as it comes towards us and as we face this. Like Dr. Hewitt said, I'm here to kind of represent a little bit of the perspective from the academic health centers, and what it will look like for us to go through this. But it's not just a reimbursement type change. It really is kind of a shock to the way we are going to get paid for a lot of the things that we all do, taking care of patients. And so just to take a little step back to look at what is happening and what this is going to look like, there's kind of two headwinds that I see that we really are going to have to face. The first one being that the big policy shift in 2028 where the government has said that they are going to start ratcheting down Medicaid payments to meet the Medicare levels. And so for states that went through the expansion, what they're looking at is that these Medicaid rates that are being paid having to come down and meet 100% of those Medicare rates that are established. And for states that didn't go through expansion, it's at 110% for that reimbursement. And so what that means is when we look at most of these states and how that works, we see a lot of the IGT or governmental enhanced payments. So these Medicaid rates that they see, the states then supplement on top of that. And this is just to make sure this is not fee-for-service Medicaid. This is for your managed care Medicaid. But what they do is they kind of you send some money to the state and then they match it with for some federal dollars to come back, and you actually get an enhanced payment on these Medicaid managed care patients. And what that means is for every dollar that you can send to the state for this, you might, like for instance, we get about $3 back in these enhanced payments. And this is due to that upper payment limit or being not applicable to your managed care Medicaid. So if this is, as we approach this, starting in 2028, and they start ratcheting down these Medicaid, what that means is that gap, that upper payment limit is going to be ratcheted down and narrowed to where these enhanced payments won't be there anymore. And for some places, and for a lot of places, that is a significant amount of the funding that the hospital receives to help supplement programs and take care of patients and that type of thing. So it's ultimately going to be millions, if not hundreds of millions of dollars that these hospitals are going to have to adjust for. The other thing that's coming down too is a little bit smaller, but still going to be impactful with Medicaid is the work requirement for Medicaid patients to start in 2027. In which case, patients are going to have to demonstrate that certain Medicaid patients are going to have to demonstrate that they have they're doing work or have work hours, and maybe they're doing charity work or whatever it might be to meet and receive Medicaid. And so what we're going to see there is this is going to be a new way that we're going to have to check patients from not hospitals themselves, but it might be that a patient comes in with this Medicaid, and do they meet it? Can they renew it? It might be that you submit a payment for Medicaid and it gets denied because the patient hasn't met those requirements. So we might actually see more patients getting pushed into the self-pay or other avenues of which payment. So it's ultimately going to affect us as well as the Medicaid changes and the requirements to get Medicaid is there. So when we look at academic medical centers, how's this going to affect us? We really have kind of those big three roles. We do the high acuity, trauma, ECMO, these things that kind of we bring into the academics. We see some of the teleconsults, the support into the other hospitals, into our areas, the transfers that we see come in. And also we are training the residents and the fellows to go out into the community and practice. And so we have a large role that we have to pay for and of course support when it comes to the financials. And as we look at what our current budgeting is to meet the current need that we're seeing, if we're now facing a headwind of $150 million reduction or $75 million reduction in 2028 and then another 150 the year after, we have to really take a look at and adjust what that might look like for us and how are we going to continue to support the mission of the academics that we have. So we look at a couple of things, right? We look at our trauma readiness. How much are we going to be able to support? Of course, we ourselves at Louisville are level 1. How do we support that? And that's through our trauma center, through the quality improvement nurses that do the data extraction, all the supporting efforts to meet that level 1 criteria to meet the care for those patients now has to be budgeted in another way. So what does it look like for us as those patients come in and we lose that funding? How are we going to adjust budgeting for that? How do we pay for OR modernization? How do we make sure that we're updating our ORs? We are currently in a hospital build phase. How do we pay for those things to support the ORs and the increased surgical volume that we're seeing as a driver for reimbursement? And so how are we going to fund that? And so those are going to, we think that, those types of things are going to suffer a little bit, right? Because we're not going to get the reimbursement that we had, mixed with workforce pressures that we see in trying to hire the people for these areas and the nursing staff. So that kind of support in an academic setting that specializes in those areas is really going to have to be looked for elsewhere. If this funding really does decrease in the way we think it's going to. When we think about from an academic standpoint, when we look at residents and fellows, most of those, of course, we know is supported by the Medicare, but we supplement a significant amount of that through our Medicaid enhanced payments. So those payments come in, and we look at that money as being also a way to supplement having increased number of residents, looking at increased residency spots or fellow spots, because we try and go above if the need is there for residents. And of course, if the ACGME is approving these positions, we want to support that educational mission because we know the need is out there. But if we're losing the ability to help supplement and pay for that, now we have to think, okay, maybe we're not approving new residency spots. Maybe we're not able to train the breadth of the resident cadre that we want in the surgical specialties, which will ultimately impact downstream that we're now not putting out good surgeons into the community. And so we're worried a little bit about how we're going to create that supplementation to meet that need. While also now we're not getting the Medicaid supplementation or the increased Medicaid payments. So now we think, okay, part of that money goes also to supplementing the academic time of the teachers that teach these residents and fellows. So we supplement that money to the university to help supplement the educational time and mission of those attendings. Well, if we don't have that money now, or we're starting to really budget down, now we're saying, okay, the surgeons, we need you to see more people, or we need you to generate more RVUs. We need you doing the procedures that help reimburse us so that we can meet just the business of operating the hospital. In which case, now you worry, okay, now am I cutting into the academic time of some of our surgeons and attendings, which is limiting their time with the residents and fellows down the road. And that's a big one, right? Because we want to, as an academic center, the big pillars, of course, your education, your research, and your outreach and in the patient care. But what might have to be reduced to meet the need with the decreased reimbursement? And so we don't want it to be, of course, the actual patient care. We don't want it to be some of the outreach efforts that we do. So what does it look like when it comes to the educational mission and workforce that we have? And that's a big one for us, right? The other thing too is how in this atmosphere where we're looking at such a decrease in revenue, how do you continue to expand and reach out into the community to support what is going to, I know Dr. Watkins is going to talk about in the rural areas is, okay, what does it look like from a referral base? Are the patients still coming here? Are they referring? If they're not, or that referral's not there anymore, or we lose some of those rural systems, okay, that's a decrease in patient volume for us and a decrease in exposure, a decrease in the patients that we see, and ultimately that's downstream revenue that we lose and downstream educational mission that we lose. And then those patients also, if they're now uninsured or they're now looking at different ways or self-pay, they're usually waiting until they're sicker before they reach us, right? And so now you're seeing these patients come in a much different state that is requiring more resources to take care of them when we really could have had that opportunity earlier on if we had those resources out in the community to provide for that. And so it's very multifactorial when it comes to what these patient volumes are going to look like. We're not sure. We're trying to project what this is going to look like already, looking at our workforce and efficiency, but once we get there, it's going to be a big change in how I think an academic center is really going to have to approach surgical care and patient care within the hospital systems. So that's a lot. I think I could go on forever, but I'm also looking forward to hearing what other people think. So I'll hand it off to Dr. Watkins to give us a little bit of what the rural health is going to look like and what he sees out there.
Thank you, Dr. Schaff. It's going to look a lot different. Um, First, I want to thank the Southeastern Surgical Society for um, having me do this, and I appreciate the opportunity to be on this panel with the other esteemed members. And um, yeah, it's a little different picture in rural America. A little bit about me. I'm a board certified general surgeon, a fellow of the college, Louisville trained back in the day, and I've been a rural surgeon for almost 30 years. I was recruited to Campbellsville, Kentucky by Dr. Shively, and I'm forever grateful. The emphasis of my practice has been on minimally invasive surgery and endoscopy, and since 2019, I've been a robotic surgeon. Um, Approximately 4 years ago, I took the role as the first chief medical officer for our hospital, and knowing a fair amount about physician leadership and very little about administration, I enrolled in the Emory's Gazetta School of Business certificate for healthcare administration, particularly focusing on being a chief medical officer. And I'm grateful. I learned a lot. I'm not sure if being a surgeon helped me more as an administrator or learning more about administration helped me more as a surgeon. We can argue that at a later date. So, Taylor Regional Hospital is an independent county district hospital in central Kentucky. Sadly, we're one of only six independent hospitals left in the state. We're an 80-bed facility, a regional hospital. We have an 8-bed ICU, and we support multiple surgical service lines: general surgery, ENT, urology, orthopedics, OBGYN, and others. We have a long history of that. And I want to take a moment to give Dr. Shively some credit. He was the first general surgeon. He came home to Campbellsville and he recruited board certified academic trained general surgeons, including myself. And now, as the quote senior surgeon in the group, we will continue to do so. We've always had a very strong urology presence. Dr. James Angel, he now has two children, Dr. Ben and Meredith Angel, who continue his legacy, and Dr. Jim Ewing in ENT. He has a son, Jimmy, who I trained with at Louisville, and he continues to lead the ENT service line. And so we're serious about providing surgical services. And we're not just doing this kind of haphazardly. We do it in a very strategic manner. So we're lucky enough to have 5 totally integrated ORs, a cysto suite, 2 endo suites. We are a Committee on Cancer accredited center, thanks to Dr. Shively and others. And we just recently added a new linear accelerator, state of the art. And we are committed to try to change healthcare through technology. We were the third hospital in the state to have a Da Vinci 5 robot. Our urology colleagues are now doing NanoKnife for prostate cancer and aquablation therapy. So we are committed to trying to be on the cutting edge as much as we can in rural America. So what does the bill do? Obviously, as Dr. Schaff talked about, it's a large Medicaid funding cut, stricter eligibility for participants with verification potentially of their work requirements. And the result is going to be increased patient cost sharing and limits on provider tax options, which is a huge thing for us that rely on ATRIP. There are going to be significant coverage losses, reduced reimbursements for hospitals. And ultimately, this bill does 2 things, in my opinion. It limits access to healthcare, and then at the same time increases the burden of healthcare, not just to patients, but to rural hospitals, urban facilities, and academic centers. The potential economic impact on Kentucky, the estimated loss from both eliminating the Medicaid expansion program and the Medicaid cuts is approximately $6 billion. Just for scale, The proposed general fund budget for Kentucky for 2026 is $17 billion. So about a third of the budget, or a little over. So why are we vulnerable as a rural healthcare facility? Well, most rural hospitals, including ourselves, operate on very thin margins. And it's estimated that nearly half the rural hospitals in the country are potentially at risk. Medicaid accounts for a large share of revenue in rural hospitals. We, in general, have lower private insurance penetration, and we have older and sicker populations, and we have a lot of social determinants that make healthcare and present barriers for healthcare that are unique to the rural areas. So there are some important service lines that are not profitable, and unfortunately, those are going to become very vulnerable. So we have unique challenges in rural surgery. To operate operating rooms, it's an expensive infrastructure. Just to have the ORs, the equipment, particularly in Kentucky now, the ability to provide anesthesia coverage is quite expensive. We are under quite a bit of pressure as far as what it costs to have anesthetists and anesthesia providers. And surgery requires a multidisciplinary, very specialized staff. We have to have reliable case volumes in order to be financially viable. It's a very high fixed cost to run those types of operations. And if you scale down, it's hard to do so without exposing service lines to loss. It's very difficult, despite, in no matter to these cuts. It's always been difficult to recruit to rural areas, and it's also very difficult to retain surgeons and the team that is needed to run an OR. So the impact for accessibility, hospitals may have to close or eliminate certain surgical services. Delays in surgery, emergency surgery result in potentially worse outcomes, morbidity, mortality. Patients are going to face the burden of higher travel requirements and financial burdens. Instead of just being off for a couple of hours, they could potentially be off for a day. And these are people that are making ends meet and doing the best they can. And so that's a huge burden on them financially. The Delta outbreak during COVID showed us that when the urban and tertiary facilities are saturated, they're not able to absorb the rural patients that need their care, and that poses a potential real problem. Our goal as a rural regional facility is we want to absorb as much as we can and offload as many patients as we can from urban and tertiary facilities, academic facilities, so that we can give quality care to those that we can, but that will allow them to have the capacity to accept transfers when our patients' needs exceed our capabilities. And that can very well go away. There's going to be an impact on the workforce. It's already difficult to retain and recruit surgeons, anesthetists, OR staff. Reduced elective surgeries in specialty cases. At some point, service line contraction, elimination is inevitable. For years, we've been able to cost average or cost shift within our small organization so that we could have non-profitable service lines to provide needed care for our patients in our community. I'm afraid that will become obsolete. Profitable service lines are going to be needed just to feed the bottom line so that we can remain viable. The potential losses in a community like ours could be obstetrics, orthopedics, even ENT with its long history here and many others. And so fewer services, fewer staff, it's a downward spiral as the cuts continue. There's going to be an impact on quality and impact on outcomes. Uh, Underfunding is going to lead to hospitals like Taylor Regional not being able to have a DV5 robot, not being able to do aquablation. At some point, our equipment becomes outdated because we don't have enough capital to purchase new equipment and state-of-the-art equipment to stay current. And ultimately, we're not able to change healthcare through technology. The technology gets old, and we become somewhat obsolete. Lower surgical volumes. Also, as surgeons know, the less you do, the less you're good at, and so proficiency and outcomes can suffer. And then delays and deferred surgeries. We were a part of that during COVID, and the cases, simply as simple as a cholecystectomy, were very difficult. Operative complications, readmissions, all those things that matter become worse when patients aren't able to get the care that they need. On a more community scale, our hospital is the second largest employer in the county. A lot of counties, the rural hospitals are the primary employer. And so when you lose surgical services, you lose jobs. That results in fewer people in the community. People are going to go where they need to go to work. And so there's less local spending. Local businesses, housing markets are all going to suffer. Community confidence in their healthcare delivery system is going to suffer. And ultimately, these counties are going to decline both in number and in growth. Kentucky is a unique situation. There are many analyses that show that up to 35 hospitals in rural Kentucky are at risk because of these cuts. That's the most of any state in the country. Hospitals that are at risk were identified as having a high Medicaid payer mix and fragile margins. We certainly have high payer mix for Medicaid, and thankfully, through strategic leadership at our hospital, we have been able to be profitable for the last 2 years. Otherwise, I feel certain that Taylor Regional Hospital would have found itself on that list. Losses of these rural hospitals is going to increase travel distances for people that can't even come to their local hospital. We have a transport service. Without that, there are many people that couldn't access health care. And so when you ask them to go 45 miles to Elizabethtown or an hour and a half to Louisville, Lexington, it's going to cause a huge strain on them. And then when they are able to travel, I think it's going to put a huge burden on the referral centers and the rescue centers. So, what can we do to mitigate this? I have a whole slide that I'm reading from, but quite frankly, there's just not much we can do. Honestly, I look forward to hearing Dr. Green's solution. Clearly, in Kentucky, when it takes up that much of your budget, there's not going to be a safety net for rural hospitals. I don't see that. We already do a lot of things to recruit and maintain our provider base, but it takes more money to get people to come to rural America. And if we're making less money, we can't spend more money. So I feel like our workforce on the provider side is threatened by this. I think ultimately community advocacy, where people go out and vote and try to make a difference. But sadly, that's a long-term plan. The short-term and the medium-range plan is scary. It's a scary time for rural healthcare, and quite frankly, I think it's a scary time for healthcare in the United States. I could go on, but I appreciate the opportunity to try to illuminate the challenges that we have in rural Kentucky. I appreciate the opportunity to be a part of this panel, and I look forward to questions and thank you for the time.
Thank you, Dr. Watkins. Really appreciate that. Pass along to Dr. Todd, who's going to speak from the point of view of safety net hospitals.
Well, once again, thank you, and thanks to Southeastern Surgical for the opportunity to be here today. And James, thanks for that. That was really it'll make mine not seem so grim. While it's still pretty grim, it's not going to seem that grim, I think. But everyone's kind of talked a little about what this looks like, and if it's okay, I'll probably take it through the lens of Grady, which kind of gives you an idea of what a safety net might look like. For perspective, Grady's 1,000 beds. Safety net, kind of a unique structure in the sense that we're not run by the counties. We are partially funded by the counties, but minimally funded. It's a private partnership that really runs it from the board perspective. So we're a little unique in that situation. But obviously the only safety net for the greater Atlanta metro area, truly. When we look at Medicaid, and we've kind of been working with our chief policy officer and a lot of advocacy in DC trying to mitigate this throughout the process, obviously not with limited success, but there are several things that kind of came into play for us. And one was Medicaid redetermination. That came right on top of this. Not a part of HR1, but Medicaid redetermination coming out of COVID for Grady was $100 million overnight loss that we were previously receiving. So that just kind of adds to the impact of HR1 coming out. We talked a fair amount about subsidies, the ACA subsidies. Obviously, those are not going to happen for next year. And talking to our chief policy officer, there's realistically not going to be anything happening in the next several months that'll even clean that up for 2026. So our assumption is those are gone for 2026. For an institution like Grady, where we are at about 25% Medicaid population, that's about another $89 million is our projection. We don't really know. In the state of Georgia, it's about 350,000 to 750,000 folks will lose their insurance is the projection off of the ACA subsidy loss. We don't really know that number because we don't know who will be able to afford it or whatnot. So you're kind of guessing, but our best guess is that's about another $89 million annually we lose. So right there, you have $200 million in the hole that you previously had. So that's real money. Perspective-wise, Grady's about a $2.5 to $3 billion organization. We've been incredibly fortunate through a lot of different efforts and initiatives growing our private insurance base of having a 5+% margin in recent years. So we have a little bit of wiggle room when it comes to this. But what that does mean is what was going to be a 4% margin this year is now going to be about a 2.7% margin for us, which is pretty razor thin at that price point. We talked a little about the work requirements. Obviously, it's interesting. Georgia already had some work requirements in place. So that's a pretty nominal number for us. We're actually least impacted by the work requirements. About 7 million is our anticipated 2027 impact on that. And then you get to the directed payment programs that Hugh spoke so nicely about. For us, the direct payment programs really were a game changer. And obviously, that's where the Republicans really focused on that it was a bit of a boondoggle, so to speak, or, kind of fraud and waste. It really allowed us to function at a totally different level from that perspective. We're projecting that, it's 10% decrease every year for 10 years until you get to 110% since we weren't Medicaid expansion. But for us, that's about another 35 million annually we start losing in 2028. So you can just start adding up the math and you're up to $250 million annually within about the next 3 years will be down. So that's real money when you're already at a relatively small margin. On top of that, some of the other stuff that we haven't talked about yet is their 340B program when it comes to drugs for underserved populations. Most of all of our hospitals are using that very extensively. And the biggest change on that is used to you got paid up front. Now what's going to happen, you're going to have to get a rebate. So the hospitals are going to assume that cost up front, apply for the rebate on the back end, which means you're going to have a pretty substantial cost. And that's just on those initial 10 medications. That list is going to continue to grow realistically. And so that just kind of adds insult to injury when we look at it from a 340B perspective plan. It all sounds pretty grim. I think, we've all talked about it. The biggest thing we've kind of focused on as an organization is we're not going to cut services first and foremost, and we're not going to have rifts. We're not going to lay off employees. Those have been our two promises to the institution and organization. That gets very tough very quickly. Our mantra this year is 4% better. So we're looking at 4% cuts across the organization. And it is interesting when you start looking, you realize you can get pretty fat pretty quickly. So there are opportunities where we can cut stuff that really doesn't impact anything, doesn't impact workforce, doesn't impact care. We do a lot of things that are really niceties that probably aren't necessary. And this sounds crazy, but we have tons of free lunches. You start adding up lunches, travel, and all this stuff, and other things that are kind of more impactful, but you're cutting all that stuff back. And so it really is kind of quality of life stuff for us right now. But you talked about with the academic partners. For us, our partners are Emory and Morehouse. So also partner with Emory and Morehouse, saying, how do you guys cut back some? And you said it specifically, that admin time, the teaching time, things like that. What does that look like? Realistically expanding, training programs is off the table altogether. Especially most of us are already over the cap anyway. So you're looking at APP workforce, which is expensive from that perspective. When we step back, we kind of focus, Atlanta is unique, and I think it's probably true for a lot of safety nets, but Atlanta's a unique city in the sense that if you go back to the days of redlining, Atlanta, is divided by I-20 north-south. Anything south of 20 is a healthcare desert. The only hospitals that have really been south of 20 or even around there have been closed since I've been in Atlanta for 6 years now. So there really is no good healthcare south of Grady since we're positioned in downtown Atlanta. We really focus on trying to provide care in the neighborhoods where our patients are. They may be miles away, but for them, that's an all-day affair to get to Grady via public transportation, taking time off from work, getting daycare for kids, you name it. It's very challenging for our population. And so we've been expanding our neighborhood health centers. We've added adding two more this year. So we'll be up to 10 neighborhood health centers. And they're all strategically placed based off of where our patients are and where the access and need is, basically. What that means for us is, we're not expanding those probably anymore after this year, realistically. We just can't afford to continue to expand that, which is really devastating for our patient population because it allows them to have that care in their neighborhoods, close to home, better access with rapid transit, things of that nature. So it really is kind of a detriment to our patient population. We're also in the process of building a South Campus, trying to fill that healthcare desert in the south part of the city. We've broken ground on a freestanding emergency center, which will open this coming summer. Plans for a medical office building and about a 300-bed or so community hospital. It's about $1 billion proposition. When you're asking for 300 million from philanthropy, 300 million from the government, and then us ponying up 300 million, that looks very different. It's a very different proposition. Grady is interesting in the sense that we have zero debt. We've never taken on debt. And so what that means for us is if we're actually build that hospital, we'll be taking on debt for the first time. It's just something we've never done as an organization. So we have to restart thinking is how do we do that? Our mantra right now is we're not going to survive by cutting everything. We're going to survive by growing. And so our strategy is how do we continue to grow, especially in some of these areas that are profitable. James, you kind of alluded to it. How do you build those service lines that are strategically profitable so that you can support some of those other service lines? Our biggest issue is we don't want to cut things, but you start looking into the softer things, and that's the hardest part, the psychosocial support and things of that nature. We have a lot of wraparound services on the back end for our patient populations that are grant funded, that are philanthropic funded, that start getting cut. They really need our support, and we may not have the ability to support those programs. And that's very tough. We've stood firm saying we're not going to cut those, but at some point you have to start looking at every option and what that looks like. James, you were talking about also service lines you cut. When we look at non-profitable service lines for Grady, OB and mental health services, those are the two biggest ones, unfortunately. Grady is the largest supplier of mental health services in the entire state of Georgia outside of the penal system. So for us cutting mental health services, that's just not an option. We don't have that luxury of getting rid of mental health services. We also really don't have the luxury of getting rid of OB services. So it is a very challenging thread you kind of weave when you're trying to look and see what do you cut and how do you survive from that standpoint. Our biggest strategy right now, we've been focused on this for several years now. How do you actually stay ahead of times? Ours is a belief of growth rather than retraction. And so we're trying to figure out how we continue to grow in these strategic areas, strategic parts of the city to continue to expand that access. That's the most important things for our patient population. So I could go on and on also, but I think I'll kind of open it up and let Wendy kind of take us over and have a little bit of a panel discussion.
Thank you all so much. I really enjoyed everybody's insights, and yes, I do have some solutions, and I think you all touched on them. First, you brought up that the time that we're facing right now is the canary in the coal mine. We are seeing it, but that allows us to act and react to it. So we aren't dead yet. If the bird is flying, we still have a chance. And then James brought up the option for how do we address Medicaid expansion? Well, that is a voting decision. That's a we the people. So, yes, we still have options and opportunities to try to do what the American College of Surgeons motto says, to heal all with skill and trust. And I see this truly as an opportunity as we look at the rural health community to say, this is our opportunity to get it right. If we can get it right in the rural health community, the services that are needed, improving care in that space, then it'll help improve care for all. And how do I know that can happen? Well, because we did it with the Disabilities Act. When we had looked at the curb cut effect, where we looked at individuals who could not initially cross a crosswalk because there was a barrier there. And then we made these curb cuts that allow all to be able to roll their bicycles, their whatever device across there, and those who needed wheelchair assistance were able to move more freely. It made us all better. So I really do look at this as an opportunity to heal all, and especially as we're looking at the most vulnerable populations. It is, our life's work to take care of the vulnerable populations. And right now, we see that there's an attack on maternal medicine. It is the most expendable, and we see it closing at the fastest rate across our rural hospitals, which is another canary that we need to be mindful of. And if we want to grow our population and educate our population and allow our population to thrive, we're going to need to be more intentional in those spaces. And maybe have to reimagine what that care looks like. And that's where some of the rural health initiatives coming in, this is the opportunity that we have. How do we reimagine care? Maybe it really is that people don't need to deliver in the hospitals. That's okay. Maybe we need to go back to more of a doula-based practice where more people are delivering in spaces and places that don't require a hospital, but their citizenship does not need to be concerned. People don't need to have concerns for their citizenship if they deliver at home, which may be one of the ways that if the birthing process happens outside of an institution, people may have challenges in that space. So there's always a risk benefit, but I think it's a strong opportunity for us to reimagine how we can improve care. We have people who can't eat. In the surgical population, we have a lot of intestinal failure due to intracutaneous fistulas, short gut syndromes, pancreatitis, necrotizing pancreatitis, and people can't eat. And one of the most challenging areas for the patient population who may end up in our tertiary care centers is, okay, so now we start a method of treatment of giving them nutrition IV, but we don't have a way to continue that. There's not the infrastructure, the additional services to deliver them the basic nutrients that they need to be able to survive. How do we make care more equitable in that space from a surgical perspective as we try to address some of these looming issues across the spectrum? There are a number of opportunities, but I would say basically we have an opportunity to look at the rural healthcare system as our opportunity to initiate change, even if in the we create centers in the rural community, similar to what Dr. Watkins has, where it's not the 4 hour drive, but it's the 1 hour drive. And we at the centers in the urban community spend time where there is almost like we we do a rural health rotation where the faculty go into those communities. And this is me speaking with some of my colleagues in the rural health space, and one in particular, Dr. Damon Brantley, who has given me such great ideas as to how we might be able to address and create partnerships with with the rural hospitals, where we, as the surgical workforce, go into these communities and help to alleviate some of the burden and burnout that can occur when there's one or two physicians at a hospital that are covering every other night, and be able to give them some breathing room at their hospitals in partnership to trying to keep them going. So there are some short-term solutions that may be a bit more challenging, but we definitely also need to look at the long-term solutions where the academic institutions need to have a track of a learning track, an academic track for rural surgery, rural health, so that we are helping to show the importance of keeping that community going and thriving. Pouring into those communities, using our resources, and one, it helps to offload some of the work and allows patient satisfaction and improve patient care for them to be able to be cared for in their community in a way that is important and impactful and meaningful for them. Thank you.
Thank you so much, all of you, for your comments. This has been really great. I've been taking notes myself, learning a lot as everyone's speaking. I know that we do have some attendees on, and I would encourage you to put your questions in the chat if there's anything, that you would particularly like to ask someone. This can go to anybody, but kind of directed at Dr. Green. I think you speak about advocacy and the role that surgeons can play. I think sometimes, these days it's very easy to feel overwhelmed and like, nothing you can do can have an impact. But if you could just speak a little bit more to, really what actionable steps, if someone's listening to this webinar and says, yes, this is a problem and I care about it and I want to do something about it. Where's the best place to go? Where do you start?
Well, I would start with the American College of Surgeons PAC. That is a great place where the advocacy can work on a national level, but always politics is local. So we have a Georgia Advocacy Day, and coming up in January, it may not be your area of interest, but they're going to be talking about maternal health. Right, we aren't in that space, but if we advocate for the most vulnerable, the unborn child, what better place to put our efforts and show that we can link up with other groups and try to say, what are we going to do for this group? Because it is that canary of the first services that will go are the obstetric services. So that means we need to be advocates in that space for that patient population.
The other thing, Kelly, I would just add to that. I mean, I think we often aren't that politically involved. Our House representative members are often back in our districts quite frequently. And really taking the opportunity to go meet with folks and tell them patient stories. I mean, I think that is probably the most impactful thing. And I don't think we can take credit for it, but I know a lot of our team has met with Marjorie Taylor Greene a fair amount. And if you actually listen to her more recently, she actually talks about trying to extend the ACA subsidies, and it actually is, kind of pushing back on the Republicans and Trump, saying that this is impactful. So much so that she actually kind of started talking about what that would look like for her kids. And so, I mean, really being able to spend time with your representatives and let them understand the true patient stories and those true impacts, I think it's actually much more impactful than we appreciate. And they're often in their home districts. We have time, and it's really taking that time to go meet with them and start building those relationships. And I think, Wendy, to your point, I mean, that's where the college has done such a great job with the PAC as far as building those relationships. It's so much more impactful if they get to know Dr. X back home, someone they can listen to and they trust, rather than just talking heads. So.
And March is Leadership and Advocacy Summit in DC every year, and they help to train surgeons on how to go and share those stories. So we're the mouthpiece for our patients. What else, that's part of our mission, is to speak for those who don't have a voice. And the people who don't have a voice oftentimes are our patients who are caught in the middle of these challenges, and we see it coming. But we need to advocate more. Besides just giving them the medications that they need or the surgery that they need, we also need to advocate for the public health population that needs to be served.
Great, thanks. I also would like to put it out, I love having these different perspectives. Um, you know, Dr. Watkins or Dr. Shoffley, what would you ask of each other, right? If there's something as you both face this impending crisis, as someone at a rural hospital, what would you ask of your academic referral center, and then vice versa? How can we help each other out in all this coming down the pike?
Honestly, I don't ask anything more of Dr. Schaff and the University of Louisville or the University of Kentucky than they give us already. The onus is on us to allow them to have the capacity to take care of patients that we can't service because of our limitations as a rural hospital. And so I thought it was interesting, Dr. Todd. I mean, the magnitude of the cuts for you and the money. I don't want to disclose too much, but let's just say hypothetically there's a hospital that operates on about a 2 to 3% margin, and that is $1.8 million. And you have 750 employees that live in a community of 13,000, and you have to provide them employment. And in that in that scenario, your hospital is looking at cuts of $20 million a year. You know, I appreciate all of the high level manipulation and assertions, but the bottom line is none of your hospitals are going to close. Now, maybe some of Dr. Schaaf's in his network might, uh, but the reality is that there's only 6 independent hospitals left in the state of Kentucky, and you the University of Louisville, the University of Kentucky cannot absorb every rural patient. It's a third of the population. They cannot absorb that. It's not about profit, it's not about revenue, it's about capacity, it's about the ability of these people to access health care. For us in rural America, this is more of a guttural thing. I didn't intend to be here. I thought I was going to be an academic. I wanted to be an academic. But, God has a sense of humor, and here I am. And so I really feel strongly that the impact on rural America, it's easy to gloss over it, but there's going to be a tremendous influx of patients sicker than you ever imagined if hospitals like Taylor Regional, Springview, Jane Todd, TJ Sampson, those are all on the list. When we go away, the healthcare in Kentucky is going to collapse. And so we really have to find a way to be able to provide access for these patients and to offset the burden so that you all can do what you need to do. Dr. Schaaf, you have to train residents. You have to be able to do that. You can't do that if you're trying to survive. So I'm maybe I'm biased too much, but this is a real threat. We are a viable regional hospital and we are vulnerable. So I think we need to pay attention to that and we need to act on it. And it's not just a theoretical concern. As an administrator, this is something we deal with every day. And not to disclose too much, but my friend Jason is in Washington trying to make sure that Kentucky is viable as a healthcare system, not as a university, not as a regional center, but as a whole, because we are very vulnerable right now. And I just want to make sure everybody understands that. This is not some theoretical game. This is not some pie in the sky thing. This is real for hospitals like us and many others.
Yeah, and just to echo, James mentioned glossing over these rural hospitals. We can't do that, and so the only thing that I ask from an academic standpoint is we continue to keep communication. Like we need to know what's going on in those communities as well, because just like you said, I'm not going to ignore the fact that you're at risk, because if you're at risk and you're not there, it only means that we are not serving the people we want to serve, as well as those people are coming to us now. And so what are we sacrificing to meet that need? And now you just can't, and now they are, like you said, they're sicker, they're traveling longer, the cost is higher. It doesn't make sense in the realm of efficiency to do that. And so that's where I think we have to continue the lines of talking to each other, knowing what's happening in the communities, and supporting the care we're delivering just in our area and in state, and it can expand out that. But we have to be the vocal point for that too.
Yeah, thank you for that. We do have a question in the chat that I want to make sure we get to. Someone asked if any panelists can speak to potential growth in the arena of corporate partnerships. So as we think about, I guess, staying financially solvent, is that an area that maybe some rural hospitals have thought about, or other areas?
Rob, how has Grady been able to be successful in that space that, where you have, private and public funding?
Yeah, I mean, a lot of it, I think a lot of it, you think philanthropic. I mean, the philanthropic arm is quite big, obviously, but philanthropic money typically only goes for, buildings and things of that nature. So it's not maintaining staff and clinical care. And so it allows us to expand the footprint, but it doesn't provide for the operational funding and stuff. And so I think that gets very challenging. We do focus on any possible corporate partnerships we can have, you name it, we look at it. And I saw their comment was AI, IT, and things of that nature. How do you expand into those as much as possible? That's tough though. I mean, that money is only so far, and usually that money is more R&D type money, not that we want to help maintain your hospital money. And so I don't know if there's a real opportunity. I don't know if you guys have explored that at Louisville at all, but we try to tap into everything we possibly can, but it's limited at some point.
Yeah, I think you're right. I think they're throwing around the idea, but then once you start looking into that, what kind of door are you opening in the sense of that the partnership? What's the expectations? What are they really partnering for? Because you're right, a lot of times it's a name on a building or something functional so that they get something tangible back out of it. It's not, I'm going to pay for 5,000 OR surgeries this year, right? They just that'd be great. The way you put the corporate name on the surgery on the way out, but that doesn't happen. And so, yeah, it's there. We see that, but how do you really funnel it to where it's needed and not just in something that benefits a corporate entity?
So Hugh, we need NIL for surgery.
Yeah, right. Yeah, we can trade off.
Yeah, the residents, we just need to get some real big social media accounts going for general surgery residents. There you go.
Yeah.
I just hope Brett Favre can still get some. That's all I can say.
I think there was one other point that was brought up about the quality and safety piece that was important. I didn't want to lose track of that the college is working on the trying to decrease the cost for the hospitals that are trying to remain a part of the quality and safety systems by using large language models in conjunction with Epic to try to help increase the data that we're getting and decrease the human capital that it takes to be able to achieve that. So more to come in that in the future, but there are some AI-based opportunities for us to streamline some of the care and quality opportunities that we want to see, especially as we try to move towards getting broadband access in communities that have limited resources.
Well, I think we're approaching the end. Does anyone want to make any final comments before we wrap it up tonight? Maybe I'll ask each of our panel members to just give us a sentence or two to close us out.
Thanks for having me. Thanks for having this conversation. I think it's a start. It's a continuation of the conversations we need to keep having. So I appreciate the opportunity to be here to speak to everybody. So thank you.
Hey, this is Manny Zervos, the president of Southeast Surgical this year. I've been listening in. I don't think my name came up, but congratulations to the committee, and thank you all for putting this together. So I also practice in a rural healthcare system. Appreciate your insight and agree with what's been said. Thank you all.
Well, I'd just like to say I appreciate the opportunity. Go ahead, Rob. Sorry.
No, go ahead, James. I'll
No, I appreciate the opportunity. The chance for rural surgery to have a voice, I think is very important. I appreciate Dr. Shively inviting me and you all having me. And I think you know what Hugh said and Rob alluded to, and certainly Wendy said. I mean, we have to communicate with each other. If we don't know each other's situations, we can't help each other. And so the 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 old town and gown mantra has to be gone. This is all about serving our communities and taking care of people and recognizing those at risk, recognizing those that need our help. And we as healers can overcome politicians every time. And so, thank you all for your support. Thank you for having me, and I appreciate the platform.
And I was just going to echo a little bit of the same and Hugh, what you said. I mean, I think one of the most important things is just education. You know, a lot of people really don't appreciate the impact of what this bill is going to look like. And James, you spoke to it very eloquently from the rural health system perspective. A lot of people don't understand what's coming down the pike. And it really is coming. And I think we need to make sure every single American, every person understands what this is going to look like. And I just don't think they understand it just yet. And unfortunately, it's going to be a little bit of experiencing it till they realize what's going on, which I think the more we can educate people today, the better off we are.
Collaborate, align, and partner. This is our opportunity to make a difference, to take care of the least of these. And if we can get it right in the rural community, we can get it right for our nation. Thank you.
Thanks. I really just want to thank all of you on behalf of the Rural Surgeons Committee of the Southeastern for spending your time. You know, I know we all have very busy lives, but obviously this is an incredibly important topic, really that, you know, is impactful not only for rural surgeons where it will be extremely impactful, but for healthcare as a whole. So thank you for your time and look forward to maybe lighting a few fires from this discussion tonight. Before we completely close out, I am going to take this chance just as a little plug to highlight the new Southeastern Surgical Congress member benefit of Connect the Docs. This was an initiative begun by the Rural Surgeons Committee. That's a mentorship program that's designed to pair rural surgeons with experienced Southeastern surgical colleagues who can offer guidance and clinical resources, best practices, case navigation, career development, training support, really in any way that we can, as an organization, help support those of our members in more rural areas. So the access is available now through the members only portal. So check that out and please sign up to be either a mentor or mentee. We'd love to get more people involved. And if you're not a member of the organization, how did you access the webinar? But you should sign up and become a member. So thanks so much for your time. I hope everybody has a great rest of their evening.